Hello everyone, thank you for being here today. My name is Pheng Cing and I'm a PRN and a DNP student at Maryville University. Today, I will be presenting my scholarly project titled Breaking Barrier, Reducing Mental Health Stigma in One Asian Community Through a Culturally Sensitive Intervention. I chose this topic because mental health stigma remains a quiet but powerful barrier within many Asian communities. People often carry emotional pain in silence due to cultural expectation, fear of judgment, language barrier, or belief that struggling emotionally is a sign of weakness. This project created a safe, familiar environment inside a local church where community members could learn about mental wellness and privately complete the PHQ-9 screening for depression and suicidal thought. In today's presentation, I will walk through the background, significance, literature, framework, methods, result, discussion, implication, and conclusion. My goal is to show how a culturally tailored approach can open doors, reduce stigma, and help individuals receive the mental health support they truly need. I want to acknowledge the support of my committee. My DNP committee include my chair, Dr. Teresa Gallicato, provided ongoing guidance and thoughtful feedback throughout the entire project. I could not have done this without her, and I am deeply grateful. My second reader, Dr. Jennifer Theo, ensured that my methodology and academic work remain strong and aligned with Maryville standard. My community member, Dr. Sarah Anlesser, helped ground this project in real clinical practice and support its implementation in the community setting. Their guidance and mentorship helped strengthen the project design, analysis, and the overall quality of the scholarly work. To understand why this project is important, we need to look at the mental health landscape within Asian American community. Asian Americans are among the least likely racial group in the United States to seek mental health services. Shame, stigma, and cultural value of saving face often prevent individuals from seeking out for help. In Oklahoma, Asian Americans face additional barriers, including limited culturally aligned resources and very few providers who understand their languages or cultural norms. Untreated depression and anxiety increase the risk of suicide, family stress, and long-term mental health decline. Because many Asian community members trust their churches more than healthcare system, community-based wellness program in familiar environment can improve participation and reduce fear. This is what motivated me to bring this project to a local Asian church where people already feel safe. This project was designed to bring mental wellness education and PHQ-9 screening directly into a trusted, culturally grounded space. This project is significant for several reasons. First, it directly addresses a health disparity affecting an underserved minority group. Culturally tailored care helps reduce stigma, increase awareness, and build trust. Second, PHQ-9 screening is essential because depression often goes unnoticed in Asian community. Early detection allows us to provide care and prevent mental health crises. This project also strengthened culturally responsive practice for advanced practice nurses. APN play a critical role in improving access and designing community-tailored intervention. Finally, the work create an ongoing partnership between the community and healthcare provider, something sustainable even after the project ends. My literature review highlighted four major themes. Deep-rooted stigma and misconception about mental illness remain common barrier. Structural and cultural barrier such as language, lack of insurance, and fear of judgment reduce access to care. Culturally responsive community-based intervention were consistently shown to improve engagement. Screening paired with culturally tailored education is effective for early identification and reducing mental health stigma. All of these themes contribute to shaping my project. Again, these evidence strongly supported the development of a culturally grounded, community-based project like mine. My project was guided by the Cultural Identity and Engagement Model, CIE model. At the individual level, the challenges make language barrier, cultural belief about mental illness, and internalized stigma. At the family level, decision making is often influenced by collectivism and cultural expectation to maintain family reputation. At the community level, shared norms, limited culturally aligned provider, and stigma continue to shape health-seeking behavior. This model emphasized that culture is core determinant of mental health engagement. Using this model helped me design a project that honored cultural belief and created a more welcoming intervention. This was a quality improvement project carried out over 8 weeks at a local Asian American church in Oklahoma. Participants attended weekly 1-hour mental wellness session covering topics such as stress, depression, stigma, and emotional health. At the end of each session, participants completed the PHQ night privately to assess depressive symptoms and suicidal ideation. Anyone with moderate or severe score who reported suicidal thought received an immediate referral. This project used a convenient sample of 50 adults. Data were analyzed using descriptive statistics and chi-square tests to identify association. This approach allowed for a practical evaluation of how culturally sensitive education and screening function in a real-world community environment. This slide shows a sample, a convenient sample of 50 Asian American adult participants. The age range was 18 to 65 years old. Inclusion criteria were simply adults aged 18 or older who were willing and able to consent. Exclusion criteria include minors and individuals in mental health crisis. The simple recruitment process helped make participants easy and accessible. Data analysis was conducted using quantitative method. Descriptive statistics summarize demographic information and PHQ-9 patterns. Scores were categorized using the validated PHQ-9 severity guideline. Chi-square testing was used to examine potential relationship between demographic characteristics and depression severity. This analysis helped identify symptom distribution and determine how many individuals needed referral for mental health services. As you can see on the slides, gender distribution show a fairly balanced sample, with 58% male and 42% female participants. This balance allows us to observe mental health patterns across both groups without one being heavily overpresent. As you can see on this slide, participants range from 20 to 69 years old, with an average age about 47. Most participants were mid-adulthood, which matched the population that regularly attend this church. These basic demographics help us understand who engaged in the intervention and screening process. The average PHQ-9 score among all participants was 12.42, which fall in the moderate range with a standard deviation of 6.34. This indicates that depressive symptoms were present across a wide range of severity. Some participants scored in the middle range, while others reached moderate or moderately severe level. These scores highlight the importance of screening in communities where stigma often prevents early detection. As you can see on this graph, participants fell across all 5 PHQ-9 severity ranges. You can see that many individuals score in the mild to moderate category. A smaller but important portion score high enough to require immediate mental health referral. This visual representation helps illustrate the community mental health need. These numbers align closely with referral I provided during the project, indicating a significant mental health need within the community. Based on validated PHQ-9 guideline, 27 participants, or 54% require referral to mental health services. Meanwhile, 46% or 23 participants did not require referral but were encouraged to continue monitoring the symptom. This is a significant finding. More than half of the participants have scored, indicating the need for professional mental health care. To summarize the key result, all 50 participants completed the PHQ-9. Gender distribution was relatively balanced. Age ranges widely, but most were middle-aged adults. PHQ-9 scores show a broad range of depressive symptoms. Nearly half fell in mild to moderate range. More than half require referral. These findings highlight an unmet mental health need within this community. Like all projects, mine had limitations. First, the project used convenient sampling from one church, which limit generalizability. The sample size of 50 restricts statistical power in subgroup comparison. Only post-intervention PHQ-9 were collected. There was no pre- or post-intervention PHQ-9, so symptom change could not be measured over time. Self-reported data may also have been influenced by cultural expectation of emotional restraint. In addition, self-reported data are vulnerable to underreporting, especially in culture where stigma is strong. The single-site design does not represent all Asian subgroups, and the 8-week timeline was too short to observe long-term outcome. Despite the limitation, the project still provided meaningful insight into mental health need and stigma reduction. These findings show that culturally grounded intervention truly make a difference. Participants were more open, more willing to discuss mental health, and more engaged in screening. The high referral rate suggests that many individuals have never been screened before, but were willing to seek help in a familiar setting. The culturally safe environment combined with education aligned with community value help reduce stigma and normalize mental health conversation. This demonstrates the power of culturally sensitive approach in shifting attitude and increasing readiness for help seeking. This project has several important implications for practice. First, culturally comfortable environment help people feel safe discussing mental health. Routine PHQ-9 screening can detect hidden symptoms early and prevent missed cases. Providers must use culturally sensitive communication, as the way we ask questions can influence willingness to share emotional concern from our patient. Partnership with churches and cultural organizations can strengthen outreach and build trust. Advanced practice nurses can collaborate with community organizations such as churches to create trust-based mental health pathway. Finally, this model can be adapted for other underdeserved or immigrant groups, offering a practical pathway to improving mental health access. In summary, this project demonstrated that culturally sensitive education and screening can reduce stigma, increase awareness, and connect individuals to mental health resources. Many community members show symptoms they have never discussed before, and the project created a supportive space for early identification. This work offers a model that can be expanded to other cultural communities facing similar barriers. If I were to repeat this project, I will collect both pre- and post-intervention PHQ-9 score to measure changes more clearly. I will also extend the project timeline and increase representation from different Asian subgroups. Family involvement and translated material may further increase engagement. Through this project and DNP program, I strengthen my leadership, advocacy, and evidence-based practice skill. I remain committed to expanding culturally competent mental health support in underdeserved community. Going forward, I plan to integrate these approaches into my clinical practice and expand mental health outreach within the community. Thank you so much for taking the time to attend this presentation. Please feel free to reach out to me with any question at pcing1@live.maryville.edu. Here are the references that supported my project. These include recent study on cultural stigma, community-based mental health intervention, and validity of the PHQ-9 tool. I use these resources to guide the project design, support the significant, and strengthen the analysis. Thank you again for your time and attention today. This project was meaningful not only to the community I serve, but also for my development as a future DNP prepared provider. If anyone has a question or would like more detail about any part of the project, I'm happy to answer them.